Hello, this is Dr. Remington Farley from Detroit Medical Center Urology Residency Program. I'm presenting on behalf of co-authors Dr. Shane Doherty and Dr. Rami Jurgis. Our faculty mentor was Dr. Joshua Palka. Name of our project, Proposal to Decrease Incidence, Morbidity, and Associated Healthcare Costs Regarding Difficult and Traumatic Urethral Catheterization, a Protocol for DMC Hospitals. I have no disclosures. Some background information regarding this topic. Difficult and traumatic urethral catheterization is a common reason for urologic consults and is associated with increased healthcare costs and short and long-term patient morbidities such as acute urinary retention, urosepsis, bleeding, acute kidney injury, and urethral strictures. These morbidities create unnecessary burdens for our patient population and healthcare system. Aim of our quality improvement project is to incorporate a protocol in DMC hospital system to be utilized by nursing staff and non-urologic clinicians for troubleshooting difficult urinary catheters. We hope to see a reduction in hospital stay, duration, and cost, minimize urethral trauma and associated morbidities, and in implementing these changes, identify need for additional staff training and create a system of reporting and documenting to assist in preventing future occurrences. We also hope to measure changes in prevalence after the protocol has been implemented to determine if a system-wide protocol may be beneficial. To better understand nursing experiences with difficult and traumatic urethral catheters and receptiveness of a protocol, a survey was taken including 4 questions. These 4 questions can be seen right here on the poster with responses right here. The 41 nurses were at a single DMC hospital and were from the emergency department, surgical ICU, medical ICU, and the floor. We now would like to implement a difficult and traumatic urethral catheter protocol in which nursing staff and non-urologic clinicians will utilize a troubleshooting checklist with algorithm if difficult or traumatic urethral catheterization is encountered. These algorithms are also included in the poster, the male algorithm being right here, female algorithm being right here. Both algorithms include troubleshooting steps, catheter recommendations, and when to contact urology. We would also like to ensure adequate documentation for quality of care metrics. Difficult and traumatic urethral catheterization consults will be tracked at 2 DMC hospitals for 3 months before initiating protocol and then for 3 months after to evaluate for reduction in difficult urethral catheterization consult, traumatic urethral catheterization, associated costs, and morbidity. Data collection before and after protocol is still in process, but results from our nursing surveys were significant regarding involvement in difficult and traumatic urethral catheterization and positive receptiveness to protocol and urology in service. Results showed overall that 44% had been involved with traumatic urethral catheterization, 90% had previously experienced not being able to place a urethral catheter. When asked about a traumatic and difficult catheter protocol and urology in service, 90% were in favor of a protocol. Support for urology in service was as high as 95%. In conclusion, utility of protocols and education could potentially reduce these burdens within the DMC healthcare system and enhance patient care while positively affecting unnecessary expenditures. Survey of a single DMC hospital showed that traumatic catheterization and inability to place a urethral catheter among nursing staff is common, and also showed a high need and desire for a protocol and education regarding traumatic and difficult urethral catheters. Further data, including nursing survey at other DMC hospitals and longitudinal data comparing patient outcomes and healthcare costs after implementation of this proposal, are needed to further evaluate benefit. Thank you.